who don't have a dilated common bile duct are going to be super thin and sometimes even harder to see. It's a little more challenging. It's the people who have some type of pathology or dilated bile duct that make it really obvious for you. In her case, it looks quite normal and very thin. So I'm going to open up my slice, and I'm going to right mouse click perpendicular onto my coronal image. Then I'm going to come to my toolbar, and I want to view this as the line box mode, so I see exactly how thick my slice is. Now you have control over how thick or how thin your slice is. You can either type in here how thick or how thin you want your slice, or you can simply just tailor it, because there's really no set thickness that you have to acquire it at. So I'm going to angle the slice sort of parallel with the common bile duct, and then increase or decrease my slice thickness so that really just the common bile duct is in my slice. Bearing in mind that it turns as it descends, so I just want to make sure that it's in my slice the whole way. That's it. Apply that. So we're going to ultimately end up with sort of the sagittal oblique of the common bile duct. Okay, Sarah, please take in a breath. Oh, by the way, Sarah, breathe normally for a moment. By the way, we're back to doing the normal, consistent breath holding, okay? All right. Just thought I'd tell you that.
Really good at aiming.
What's that?
I was really good at aiming.
You were very, very good at being inconsistent. Just as good as you've been at being consistent. So back to consistency, okay? All right, so right now, please take in a breath and hold it. And I don't tell them to breathe until breathe, I either see an image populated or this counts down to 0. Because just because you stop hearing the noise doesn't mean it's still not receiving the data. These are just one quick single shot scans. So I'll leave this image here, and I'm going to bring this image up here. Now you can see this nice thin common bile duct in the sagittal plane. So I'll leave the sagittal localizer here, my coronal slice here for now, and on my axial slice, I'm going to scroll down until I see the pancreatic tail, which is here. And again, if she had a dilated pancreatic duct, you would see it quite readily throughout the pancreas, but you can start to see it right here, and you can follow it throughout the body towards the head of the pancreas. There's the common bile duct, here's the pancreatic duct coming, getting ready to meet it. So again, I'm going to scroll through to where I see the tail. You can bring this slice over. Again, it's the same slice, so you can either bring this slice over and open it up, or simply bring this down, open it up, and I will now right mouse click perpendicular onto my sagittal image.
Coronal.
Sagittal
That's sagittal.
image right here. Right mouse click perpendicular onto the sagittal image that you just got done scanning. And now turn your slice so that you're once again parallel with sort of the same angle that the common bile duct is taking. Now come to your axial image. If we were to scan it just like this, we'd be missing the tail of the common bile duct, we'd be missing perhaps the body. So here is where you can take control with the slice thickness and just make it as thick as you need it to be, not thicker than you need it to be, but as thick as you need it to be. And then, since we were interested in the tail as well, you want to now do a double oblique. So you're obliqued to the sagittal image here, and now you're obliqued on the axial image here, where you're including the tail of the pancreas. Now you scroll through. See, I'm just grazing the body, the pancreatic duct in the body of the pancreas, so I'm going to make it a little thicker there. So I clearly have the pancreatic tail, there's the body, here's the common bile duct here, and that should do it. Any questions about that? Here we go. Please take in a breath. Hold it. Breathe. Here's the common bile duct. Here's the pancreatic duct. And we're losing it a little bit, but the back of her pancreas doesn't, the tail of her pancreas actually, you really can't see the duct very, very well. So I'm not surprised we don't see a continuation of the pancreatic tail. So on these scanners, if you like the slice position and location, you can drag it down, open it up, right mouse click on Properties, Execution, and change from a single measurement to repeated measurement. And what that will do is it will keep popping this screen up for you and you don't have to touch it again.
Oh, nice.
So we're going to run this 4 more times. Okay, Sarah, take a breath in. Hold it, please. Breathe. See how it popped up again for you?
Mm-hmm.
It'll keep doing that. If you look down here, prior to us putting repeated measurement on, it's only a flag man holding one flag. Now they're holding multiple flags. Again, please take in a breath. Hold it. Breathe. Take in a breath. Hold it. Breathe. Take in a breath. Hold it. Breathe. So once you run it the 5 times and you're happy with it, you can just hit skip or close and it will stop it. Okay? Next scan in our protocol is the axial out of phase in phase. So again, I'm going to bring up my localizers where I can see the top of the liver and the crest. Bring over the out of phase and in phase. So here we can see that we're just grazing and we're not quite down to the crest here. So we're going to open up our slices per slab. This is a 3D volume scan. It's a vibe with 2 TEs that gives you out of phase and in phase. Alright, so here we're just above the liver, and here we're right at the crest. Position your second localizer. She can handle 20 seconds, so we'll apply that. So this sequence has 2 TEs. It has an out of phase TE and it has an in phase TE. So if you look here, TE1 is 2.38, which is out of phase at 1.5 T scanners. And then your second TE is 4.76, which is in phase on 1.5 T scanners. Every 2.2 milliseconds, roughly, it changes from in phase to out of phase. And actually, if you hover here, it'll show you the opposed phase TEs, 2.2, 4.4 is in phase, and then roughly 6.6, or in this case it rounds it up to 7.15. Again, it's plus or minus a little bit, but it's roughly every 2.2 milliseconds you'll go from out of phase to in phase at 1.5 T scanners. Okay, Sarah, right now, please take in a breath. Hold it.
Awkward.
So bad.
Signal.
So out of phase, in phase, out of phase, in phase, out of phase, in phase, out of phase. You see the etching where fat and water are out of phase with each other. So you're checking for motion, checking for coverage, On an ultra short bore scanner, which is what this is, your most caudal and cephalic ends are going to not look that great because you start losing your magnetic field homogeneity. So you can see that these images start to look not so great. And then your very top images, again, not so great. Okay. So next we're going to do our axial vibe pre, our care bolus, and then our 3 runs, our 3 dynamic phases. So anytime on Siemens you see a copy reference, you want to bring from the last copy reference up to that which is referenced. So this is the last copy reference that we can see, and it's referenced up to series 14. So we're going to bring all 3 of those over together. Open up the axial vibe pre. Now this is a vibe acquired at 5 millimeters, which is the same as the in and out of phase vibe, also acquired at 5 millimeters. We used 56 slices on her last vibe, so you know that we're going to need 56 slices for this upcoming vibe. So I changed it to 56 slices, and now I'm going to simply copy the default center of slice groups to the in and out of phase vibe. Okay? Move you over a little bit. 23 seconds, she should be able to do just fine. If you find that she cannot hold her breath for 23 seconds, you could perhaps open up the field of view a little bit and utilize rectangular field of view. So maybe go to a 36 field of view if necessary. So now we got down to 18 seconds. Okay? But I think she can do just fine. So we'll keep it where we were. And we'll apply. Okay, so now we're ready to do our pre-imaging. Okay, Sarah, take a breath in, please. Hold it. Opens. It will always ask you if you want either automatic or manual shim. Always, always manual. Just volume, excuse me. Always pick manual. If you don't pick manual, you're in trouble. Always pick manual. Breathe. If you select automatic, it's going to try to shim your adjust volume area when you're trying to inject the patient. So always pick manual. If you don't pick manual, you're going to miss your care bolus. So if I haven't said it yet, always pick manual. Okay. So our pre's just ran. We'll look at those. Checking obviously for motion. Make sure that it did in fact fat sat, because these are fat satted sequences. And check for coverage. So we're good. Okay, so now we're going to position our care bolus scan. Personally, I scan them as sagittals. You can scan them in any plane you're personally comfortable with. The reason why I scan them in the sagittal plane is on sagittal imaging, you can see the heart up here. And you can see the whole descending aorta. You can actually appreciate it right here. You can see the celiac axis come off, you can see the SMA come off, but more importantly, you can see the heart. If you were to do it coronally, and I'll show you an example, if you were to do it coronally and position it off of the coronal, you are solely dependent on seeing the contrast only when it arrives in the aorta. You can't see it come through the heart, getting ready to come into the aorta. Whereas if you scan it sagittally, you can see it come through the heart, and then it will come down the aorta, which gives you plenty of time to give the patient a breath hold. If you do it coronally, sometimes you don't have enough time to give a breath hold, and you may in fact miss the bolus. There's nothing wrong with doing it coronally. I'm giving you the reasons why I do it sagittally. Okay? So that said, here's the descending aorta here. So not only am I going to position it through the aorta, but I want to make sure that my field of view is high enough so that I can see the heart. Okay? This scan, however, is not scanned on isocenter. It's scanned on fixed table position. Because right now, we don't want the table to move between the pre-contrast scan and the post, because then it will attempt to readjust and tune and shim, which you'll completely miss your bolus. So the care bolus is always scanned on a fixed table position. So it's going to scan right where the table is right now. So this might be distorted because it's not anywhere near isocenter, but we'll still be able to see it. Does that make sense? Mm-hmm. Great. Okay, so positioned our sagittal slice up through the aorta. You can always look on your axial images, and as you can see, the aorta, as I scroll up and down, is maintained in the middle of my slice. So now we'll apply this. So now your exam pause screen pops up for the care bolus. This is where you're going to say, yes, we're giving contrast. However much dotarem you're putting in, or whatever contrast agent you're putting in, do not hit enter. Once you type in, click down into your next screen, type in whatever you want, and then just click. Do not hit enter, because enter in some cases will continue your scan, and you're not ready for that. So once you're here, this is when you're going to arm your power injector. So that way when you hit the trigger, it's going to deliver your contrast. Then I always tell the patient the same exact thing. Sarah, this is the point in the scan where we give you the injection of contrast, okay? The scan's going to go along a little differently this time. This time, you're going to hear the noise of the scanner start first. And then, after quite a few seconds, over the noise of the scanner, that's when I'll tell you to take a breath in and hold it. You should be able to hear me pretty clearly over the noise through the headphones, but if for some reason I sound a little muffled or you can't quite make out what I'm saying to you, the only words I'll be saying to you over the noise is take a breath in and hold it, okay? Any questions? Very good. So I give the same delivery every time because a lot of times the patients are used to this point, at this point, me saying take a breath in and hold it, and then they hear the noise. If you don't mention that, I've seen it with other people where the scan starts, the patient panics, they thought they should have held their breath, then they squeeze the ball, and then you think something's wrong, but they're just asking you, should I have held my breath? So just be as clear in communicating with your patient as you possibly can be ahead of time so they know exactly what to expect. So I always tell them the noise of the scanner is going to begin first. And then after quite a few seconds, because that's the time where we're watching the contrast go in, we'll tell them to take a breath in and hold it. So that said, the power injector is now armed. We're annotated for contrast. When we hit continue, we're going to see that one slice imaged over and over and over again. It's a sub-second resolution, so just under a second it's going to refresh with a new slice, which will allow us to see the contrast circulate. You'll see it come through the anterior part of the heart, which is the RV. Then you'll see it in the posterior part of the heart, which is the left atrium. After it leaves the left atrium, it's only got one place to go, and that's to the left ventricle, up and out the aorta. So once you see it in the posterior part of the heart, start to anticipate, okay, here comes the contrast. And when you see it come down the top part of the thoracic aorta, then you can start giving your breath hold instructions. So we'll hit continue here. So here you see the anterior part of the heart, here's the posterior part of the heart, and you'll start to see the thoracic aorta here. So once you run it, and it's starting to run, you see that there's no artifact, the care bolus itself is running fine, then you inject the contrast, and then you wait. You'll start to see contrast come into the anterior part of the heart here, then you'll see it come into the posterior part of the heart here, again, right ventricle, then it goes out to the lungs to get oxygen, then it comes back into the left atrium, then it's going to go to the left ventricle, up, and out the aorta. When it gets to about here, I'm going to say take a breath in and hold it. However, I'm not going to hit stop and continue until the abdominal aorta is opacified and they've actually stopped holding their breath. So when you see it here, it should give them just enough time to take a breath in and hold it, so that way, the care bolus right now, that's okay. So that way, hold on. That way, when the contrast fully opacifies the aorta, they've already stopped taking their breath in and are actually holding it. Okay. These care bolus scans are only set for, I think, like 60 measures. Yeah, 60 measures. So I just spoke for a minute while that was going on. So once it runs out, it's going to stop and start scanning your actual dynamic scans. If it were a real patient, we would have seen the contrast roughly in anywhere from 10 to 15 seconds. We would hit the stop and continue button, and then it'll immediately scan the dynamic scans. Okay? So, let us... So we just hit stop and continue, and now it's running, right?
And at this time, she's still holding her breath, correct?
It would, correct. When the contrast comes down, you're going to say take a breath in and hold it, and then you'll hit stop and continue when this opacifies. Now it's running the first out of 3 measurements. I would tell her to breathe. And now at this point, you see it already ran the first of 3 measurements. It's got 30 seconds before the scanner will start. The scanner is going to start on its own. You're actually not going to touch any more buttons. So when this clock, do not get distracted, do not divert your attention anywhere else. Keep your eyes right on this clock. So when it gets to be about 6 seconds, I'm going to say take a breath in and hold it. And the scanner is going to start on its own when it says 0. Okay, Sarah, take a breath in and hold it. Don't breathe. Scanner starts on its own. So if you answer a phone call, if you're talking to somebody, it's super easy to get distracted from that little clock, and the scanner's going to start without you. So the first phase that we scan is the arterial phase. This is the venous phase, and then we have an equilibrium phase as your third. Breathe. On the arterial phase, you expect to see sort of this mottled appearance of the spleen. The kidneys have a blushed appearance of contrast, so they're not completely filled in. They almost look like sliced tomatoes, some people call them. You should see the abdominal aorta nice and bright, any branch vessels of the aorta nice and bright. You should see the portal vein have contrast in it, but not the hepatic veins. If you see the hepatic veins, take a breath in, hold it. If you see hepatic veins on your arterial phase, you are too late. So the first phase should have just the portal vein, not the hepatic veins. On the second phase, everything arterial should be not quite as bright. The spleen would go from a mottled appearance to a more solid, homogeneous appearance. Same thing with the kidneys. You'll still see the portal vein. Breathe, but now you'll also see hepatic veins bright. And then on the third dynamic phase, everything is sort of the same intensity of contrast, hence it being called equilibrium.
Being called a what?
Equilibrium phase. Okay, so then you will ultimately have your pre, your first arterial phase, venous phase, and equilibrium phase. We label them as arterial, venous, delayed. After you're done with these dynamic scans, we then run a diffusion. If you have a fast view, since the fast view is a non-breath hold scan and the diffusions are non-breath hold, you can prescribe the diffusion off of the fast view. Otherwise, you'll have to run your initial localizers as non-breath hold. Once those come up, then you position your diffusion off of the non-breath hold localizers. If this were an Eovis liver, you'd wait at a very minimum of 15 minutes. The longer you wait, the better the images. At least 15 minutes. If you can wait to 20, if you have time and the patient's doing okay, wait the 20 minutes to do your delayed 2 Eovis scans, which is an axial and a coronal. You have up to like 90 minutes or so to image the delayed for Eovis. Again, the longer the better. When you do your first delayed Eovis scan, make sure you see contrast in the biliary tree. This is specifically called a hepatobiliary phase. If you don't see contrast in the biliary tree, then you haven't waited long enough. Wait 5 more minutes, then rescan that axial, and then you can add the coronal.